When we first started in this area, there was only one study that had been published in this area. Since we've started, there's now a plethora of studies that have actually been published. About 10 of them have been in to address distress, and then there's actually a whole heap that have addressed other psychosocial problems such as sexual dysfunction, pain, sleeping difficulties more specifically. But in terms of the evidence base, we know that there's actually considerable evidence now for them. We know that they actually have comparable, or at times very close to comparable, effect sizes to if they were actually being administered in a face-to-face session. Well, we know the internet is not for everybody, although there's increased reach with the internet over time, and for example in Australia at the moment, I think it's approximately 86% of all households in Australia have internet access, but we know that, for example, the very senior Australians don't necessarily use the internet. So it's not going to be for everyone. There are still barriers. Some people prefer not to actually deal with their problems in front of a computer screen. They actually want that personal contact. So that it's, as I say, it's not a one-stop shop. It's not going to be the one pill that fixes everybody, but it's definitely a useful first step in perhaps a stepped care model in terms of where the other option would be no treatment. It's definitely providing a resource that isn't there otherwise. One of the things is to be aware that there are actually a number of websites out there now. Many of them are still being offered as part of clinical trials, so it's about being aware if there are trials testing these websites out there, but there are some that are quite open access as well that they can refer patients to. And these can be used both in the adjunct with existing face-to-face therapies or on their own if there aren't actually any resources available. So I think the thing is I guess to read up and be aware that these websites and programs are out there. Increasingly they're also being offered in app-based things on tablets and phones for mobile delivery. So it's just about being aware and knowing that you can actually refer patients to use these programs. The main things to remember is that only 25% roughly of people who actually have distress, clinically significant distress following cancer, actually elect to attend face-to-face therapy, so there's a number of barriers that stop them from using that. We know that from the studies we've run that somewhere between 40 and 60% of people, when they're offered online programs, actually accept them, so we are increasing the reach, and therefore it is actually a useful first step, and I'd say it should be as part of a stepped care package in terms of providing a resource for people to address their distress.